This episode of The Curbsiders is brought to you by NephMadness and the American Journal of Kidney Disease, AJKD.
Diseases.
And Joel.
Do you want to take it again, or you want to just keep it in like that, Paul?
No, it's perfect. No, just wait for the money to roll in. That's good.
Oh, gosh. Hannah, I understand that there's some sort of a contest that you've been running without our consent.
It has been a highly competitive and top-notch field of Olympic-level competitors at terrible kidney puns. Matt?
Actually, that does sound like something we'd be into.
So on all three of our, Kidney NephMadness platforms, Facebook, Twitter, and Instagram, we have been putting out a call for terrible puns related to kidneys. And you, the listeners, have absolutely come through for us. So our first pun is from Dr. David Tardio, who's an internist who working for Johns Hopkins Community Physicians in Southern Maryland. And he submitted to us via our Facebook page. So without any further ado...
Hello, Curbsiders. First of all, I wanted to thank you very much for an outstanding and informative podcast. It's a great combination of knowledge, food, and humor. Yes, Paul, I listened to the entire podcast. I do not skip over the beginning. My kidney pun is as follows. What do you call an old kidney? A has-been. Bada boom. Thanks very much again for everything. You all take care.
A has-been. Okay.
I like that one.
Yes.
I'll give that, Paul, 5 hotcakes.
Oh, God, I don't know what sins I'm being punished for. This is the worst day of my life.
Stuart,
what is going on?
Stuart, how many hotcakes
give that one
give that one, Stuart?
I'm going to give it a 5 out of 10.
Okay.
Because it's too obvious.
Six hotcakes in a full stack. So you're giving it
3.
Oh my God.
Okay. Half a stack.
That's a real thing. The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect the official policy or position of any entity, aside from possibly Cash Like Moral Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders.
Well, hi, Matt. How are you doing?
I'm doing very well, Stuart. Thank you for joining me. And, let's just jump right into it and have Paul start to scold the audience, because I know that he just can't wait to do that.
Well, I can even tell us what the show is. We are the Internal Medicine Podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. We also get to know our guests up top. This is one of those weeks where I feel bad for telling people that there's darkness behind their eyes. They skip ahead, or they're lesser human beings. Yeah, you can always skip ahead if you want to. This week I won't think less of you, but don't. But if you want to, just look to the show notes for the timestamps.
I'm pretty confused.
This is the first of many episodes that we're going to be doing for NephMadness. Of course, this month is NephMadness, and we at the Curbsiders will be basically converting the entire show to NephMadness for the next several weeks, which is going to be awesome. And this first episode here, we did a long recording session where we're going to split it into 2 episodes. The first episode that you're about to hear is going to be the Fluid Wars, where we're going to talk about lactated ringers, normal saline, the science, the physiology behind it, and then we're going to give our picks for which fluid we think you should be using. The second episode is about PRN medications for hypertension. Specifically, we dump on IV hydralazine a little bit, and then we also talk about perioperative use of ACE inhibitors and angiotensin receptor blockers. We have 3 fantastic guests. Of course, we have to have our chief of nephrology, Dr. Joel Tov. He is a regular on the show, and now he tells me this is his 7th appearance, and I think he's got to be right. We joked on prior episodes about the smoking jacket like they had on the old SNL show, the 5 Timers Club. So Joel definitely is owed a smoking jacket at this point. And we should just make Curbsiders smoking jackets because it'll be great. Anyway,
So like hotcakes. Yeah.
Yeah.
The demand is huge.
So, Joel Tov, I'm getting off track here. He's been on 7 episodes: hypertension, hyponatremia, CKD, acid base, RTA, hyperkalemia, and now the NephMadness episode here. He is our chief of nephrology at Kashlak Memorial Hospital. He's better known as his much cooler and more intelligent online alter ego, Kidney Boy, or at @kidney_boy, where you can find him on Twitter, where he employs his innovative medical education to teach nephrology. He is the co-creator of NephJC and NephMadness. In 2017, he won the Robert Narons Award for the ASN. His day job is as a clinical nephrologist at the teaching hospital, where he teaches medical students from Oakland University, William Beaumont School of Medicine, Wayne State University, St. George's, American University of the Caribbean, and Central Michigan University. He also teaches residents and nephrology fellows at St. John's Ascension in Detroit. Our next guest, Pascale Corolla, is a second-year nephrology fellow at Columbia University Medical Center. She completed medical school at the American University of Beirut in Lebanon and residency at Duke University Medical Center. Pascale is an editorial intern at Jkd, the American Journal of Kidney Diseases, and she did a fantastic job writing up the hospitalist region for NephMadness. So she's kind of our go-to person for this episode, kind of explaining all the topics. Our third guest and final guest is Charlie Wray. He is an assistant professor of medicine at UCSF and the San Francisco VA Medical Center. He completed medical school at Western University College of Osteopathic Medicine, residency in internal medicine at Loma Linda University Medical Center, and a hospital medicine research fellowship at the University of Chicago. Dr. Wray's research interests focus on care fragmentation in the hospital setting, overutilization of hospital resources, and more recently on the effects of social risk factors on health outcomes within the VA health system. Dr. Wray is also a digital media editor for the Journal of Hospital Medicine and the director of the JHM Editorial Fellowship. When not fulfilling these other duties, Dr. Wray can often be found tweeting at Ray Charles, W-R-A-Y Charles, or trying to keep up with his 2 young boys. So without further ado, here is part 1 of 2 great episodes on NephMadness.
It's great.
Oh, man, I'm so proud of you. That was spectacular.
Yeah, you did great. Good
Thank
job.
you, Paul. Stuart,
I've got a joke for you.
Nothing?
I've got a joke.
Okay, what's the joke?
All right, so 3 doctors all make an appointment to go see their PCM, an internist, a pediatrician, and an orthopedist. After several hours waiting to be seen, the physicians all get upset and leave one at a time. Who's the last to leave?
The pediatrician?
No, the PCM, because that day he was the only one with patience.
I think we should get into it, so we'll start recording now for real. We have multiple guests, so we're going to go around the horn and do one-liners. And let's start with our esteemed chief of nephrology, Dr. Joel Tov. I think people know who you are, but Joel, did you want to give a one-liner?
I'm Joel Tov. I'm a 49-year-old Caucasian male. I'm a attending nephrologist, and I spend way too much of my time on Twitter, where I play the character Kidney Boy. I spend a lot of time developing the Twitter online journal club NephJC, and I'm the co-creator of NephMadness.
That's right. And I think most people know who you are. If they don't, they should follow you on Twitter.
Give a cape.
This is my 7th appearance on the Curbsiders.
Wow.
Oh my gosh.
You get a medal for that?
Wow.
Crazy.
All right, this is my first. So I'm a 30-year-old female, born and raised, spent my first 25 years of my life in Lebanon and moved here 4 years ago now. So I'm a second-year nephrology fellow at Columbia, and me and my husband, we just spend our time exploring New York. And this is really when I want to have a kid, so I can make some funny joke about the kid, but I don't.
You just follow in Paul's footsteps.
You have so much freedom right now, and you're living in a great city. Just enjoy it. Enjoy it when you don't always have to account for like one or multiple other people at all times. It's nice.
I like the plan of having a kid for the jokes. I think that's the right motivation.
That's why I had my kids.
Charlie, why don't you give us your one-liner?
Yeah. Hey, guys. I'm Charlie Wray. I'm an academic hospitalist at UCSF and the San Francisco VA Medical Center. Excited to be here. When I'm not goofing off on Twitter, similar to Joel, I do health services research, and I'm also directing the new JHM Editorial Fellowship. So if there's anybody out there looking to sort of increase their chops about on academic writing, reach out to me.
And what is JHM?
Oh, yeah. Great question, Joel. The Journal of Hospital Medicine.
I guarantee you there are some people listening that are interested.
That was an organic plug.
It really was. It kind of, as I was going through it, I was like, am I just plugging this thing?
All right. We have a lot of material to get to, so I think maybe we can just go around. We got to get some kind of advice. I'll give you a choice. Joel, we'll start with you. How about either a book recommendation or some advice that you want to give to the audience? Or maybe you can recommend whatever you want. You're the chief. Recommend anything.
I would recommend following NephMadness on Twitter. That it's a Twitter handle that's going to keep you up to date on all of the shenanigans that are going to go on in the latter half of the month of March. That should be a lot of fun.
A lot of trash talking as well.
Yeah. So if you're not familiar, NephMadness is it's a 7th year that we've been doing this. We started it in 2013. It's an online educational game that plays out over social media. We take all the tropes of the NC2A basketball tournament March Madness and we apply them to medical education and nephrology. We're going to have 32 nephrology concepts distributed over 8 different academic regions, all set up in a single elimination brackets. We have people all over the world that are going to learn about these concepts and then pick their winners for every one of the matchups, all 31 of the matchups, kind of in the same way that you do with ESPN or CBS Sports. And then the actual winners are picked by a blue ribbon panel of nephrology leaders. And the better your picks match their picks results in fame, not so much fortune, but definitely, very limited fame. Additionally, if you're in the U.S., you can get CME and MOC credits for this. And one of the things I'm really excited is tonight we're going to do a deep dive into one of those 8 regions, the hospitalist nephrology region.
And I should recommend they all sign up as part of the Curbsiders team. Yeah, you get to say if you're with an institution or part of a team. So our listeners should say they're part of the Curbsiders team. I think that would be good.
Ridiculous.
Yeah,
ridiculous. We're gonna have like 150 people.
Pascale, did you want to give either some sort of book recommendation or some advice that you found useful that you've gotten in your career?
Advice for my career. I think actually, now that we're talking about social media, I think I do want to give the people who are listening the advice of actually being on Twitter.
Did you hear that, Colonel?
So they probably already are since they're listening to a podcast. But I worked with Matt Sparks for a while as a resident, and he kept trying to convince me to get onto Twitter, and I kept resisting, and I finally did it. And it's such a great community. I've met lots of people, and I'm actually here now because of it.
Yeah. Yeah, it's not just full of trolls. Med Twitter, anyway, is not just full of trolls.
It's not.
That's right, Doctor. You need to sign up for Twitter now.
Pascale, why don't you tell them what you're doing with AJKD?
Yes. So AJKD started this Jkd Editorial Internship where they asked fellows across the country who are if you're interested in the editorial work and seeing what happens behind the scenes when you're submitting your work to a paper. I think that was a great opportunity that AJKD gave to fellows, and me and 3 other fellows are actually part of this 1-year internship. We basically, we join probably a lot of their meetings, almost all of the meetings. We get to see what's submitted, we get to give our input, and we get to see how papers are chosen for publication, what reviewers are thinking about them, and actually we get the opportunity to review them ourselves as well. And through that, I was able to join NephMadness and be part of the writing group for NephMadness, and to meet Joel and a lot of other contributors. So it's been a great experience, highly recommended. I think, so Charlie's talking about the Journal of Hospital Medicine Editorial Internship. So definitely anyone who can be part of such an experience should definitely take advantage of it.
Right. So if you are about to submit your paper to American Journal of Kidney Disease, you know who to bribe.
All right, Charlie, same question to you. Did you have some sort of recommendation or some sort of advice for the audience?
Yeah, I'm gonna go back to the book one. I actually like that one a lot because I love sharing this with a lot of my trainees. One of the best books that I've read recently that I love is Ending Medical Reversal by Vinay Prasad and Adam Sifu, who, of course, are both very vocal on Twitter as well. But I think it's just a fantastic book that really sort of causes people to sort of rethink medicine in a lot of ways, and sort of inserts that critical mind into our learners. So I love that book. I've read it twice, and I think I've given away 2 copies already. So that's the book I'm pushing right now.
Yeah.
I think
12
it's
left on Amazon.
Okay, Stuart, what's the
It's $22.45.
I think it's worth it. I have a copy of the book. It is definitely eye-opening, and the thing they talk about in there is how, like, after something's disproven, it takes like a decade before it like is stopped being done. And I mean, I'm constantly on wards or working with trainees and students, and just like, no, that's not a thing anymore. Like we know that's wrong now, and I'll show you why. And it's hard because they somewhere along the line they've heard or they've been taught the old way. So yeah, that book is great.
Just last week, I ran into a case of with renal dose dopamine. I thought that dragon had been slayed 10 years ago. Like the first,
they're still preaching it in medical school.
Oh God!
You're telling me it's not a thing?
I'm telling you, it's not a thing.
I think that's one of the most useful things that we could do with the podcast is try to highlight practices that are no longer in favor or should no longer be in favor. We've tried to do a fair amount of that in the past few years. All right, I think we should get into some
let's do it.
Some pertinent topics here. We've already described NephMadness. We're going to do a couple topics here, and this probably will be split into 2 or 3 shows after the fact. The first topic is the fluid wars, and it looks like this one is earmarked for Dr. Williams to lead us into this.
Oh, is it?
Yeah.
It seems like it seems like the patient's name is Mr. Williams. I felt like this was his personal dig, but we can talk about Mr. Williams. He is a 69-year-old gentleman. He's being admitted for cough, fever, shortness of breath, and a diagnosis of community-acquired pneumonia. I'm sure Dr. Centaur would have something to say about that. The patient has been having trouble drinking fluids for the past couple of days. He has labs that demonstrate a mild acute kidney injury, thought to be secondary to volume depletion. And as a team, the ER intern and internal medicine intern look at the patient, look at each other, and then at the EHR, and they go through the list of options for volume resuscitation. And so I think we're going to start the conversation real broadly, and just what should be our goals of fluid resuscitation.
Yeah, sure. So I think, so that we don't get into too much detail, but I think the goal of fluid resuscitation is basically to replenish some bodily fluid that has been lost, and the goal is to restore tissue perfusion. And there's lots of ways we can measure that restoration of tissue perfusion, but we don't need to go into that. But I think broadly that's the goal.
So Pascale, how are you making the choice as a fellow? And then, of course, we're going to get Joel and Charlie to weigh in this as well. But how do you make the choice? Like, are you always choosing the same fluid in general right now?
Yes, after I wrote this NephMadness, I've been choosing the same fluid right now, actually. I have to say, before, like as a resident, I was more of a normal saline person, usually choosing normal saline almost all the time, except in diarrheal cases where I wanted to replace the bicarb. I didn't put much thought into it.
And choosing all that normal saline, did you ever run into any complications of that normal saline?
Honestly, I may have run into the complications, but I never knew it. We probably just attributed some of these complications to how sick the patient is, their underlying disease, their septic shock, all of that, without really paying attention to the fluids.
Right, and I think that's absolutely everybody's experience, that this is an innocuous decision, and you don't get any feedback by making this decision that it may be good or may be bad. That the difference between choosing a balanced solution and a normal saline solution in the largest studies that have been done is really almost imperceptible. I mean, it is measurable, but barely. Mm-hmm. And you can't expect anybody's personal experience to be able to reflect that. And this is just a classic case where you need to throw all the statistics at it to be able to see the difference between these two solutions, because they're both effective.
Mm-hmm. And as a lot of you guys know, Joel, you'll probably remember this, and a lot of you guys as well. Like when I was training, it was all the internists gave normal saline, and all the surgeons gave lactated ringers at this point.
Yep.
And I remember always going, what do those surgeons know about fluid resuscitation? And, they're all smart. But I always remember it being sort of this us versus them as to what sort of fluid we were using in these situations. And like you, Pascale, for years and years and years, it's just been automatic, normal saline. And just as Joel's describing, it was, you don't get any feedback from that decision. And I think that's what's made this such an interesting and difficult topic to explore.
Mm-hmm. Joel, I wanted to ask you a little bit about the background of this, because I had the same experience as Charlie. And then it was always kind of in residency, and you get this question from trainees once in a while. They're like, what about colloid? Like, let's give this person albumin instead of saline, instead of lactated ringers.
We were still using head of starch.
Can you kind of give us a little bit of that background, and then we can kind of go into the crystalloid versus crystalloid solutions?
Yeah. In 1998, there was a very impactful systemic review that was published in Cochrane that looked at albumin versus saline and showed increased mortality with the choice of albumin solutions. And the hospitals I was at as a resident absolutely freaked out and essentially banned the use of albumin except for in exceptional situations. Following that, there was a massive trial called the SAFE trial, published in the New England Journal of Medicine. I think it's something like 5,000 patients that were randomized to either albumin or saline. And the Kaplan-Meier curves absolutely can be superimposed on each other. There's no difference in survival. Okay. And so at first blush, this was a win for colloids because the previous data, the systemic review, had shown that colloids had increased mortality, and there was clearly none of this toxicity that we're seeing. There was no signal that the colloids were harmful. But on the other hand, you got a drug that's way more expensive than salted water, right, and it had no advantage at all. Additionally, if you take a look at the basic physiology, you would expect that you would need about 3 times as much saline to get the same volume expansion as you would get with colloids. But when they actually did the math, it was only about a difference of about 30%. Mm-hmm. So even when you look at the physiology, just the colloids weren't stacking up like they should have been, and there was no survival benefit from the drug. If you go into the sensitivity analysis, couple of signals emerge. One, the trauma patients did significantly worse than this with colloids compared to saline. And this was attributed to the lower osmolality of the albumin solution, and a lower osmolality solution could cause cerebral expansion. And sure enough, if you look at where the mortality it was in the neurotrauma patients, patients that had concussions. You didn't want to increase intracranial pressure. Using a lower osmolality solution would drive that up. The other signal on the other side was there was a not significant, but bordering on significance, was an advantage in septic patients with albumin. However, in subsequent studies, to my eyes, that has not been borne out in trials like the FEAST trial and additional studies that have looked for advantages with albumin.
Charlie, tell me if you agree. From the point of view, me working now as a hospitalist, what I'm seeing from most people is albumin is rarely a fluid we go to outside of the world of cirrhosis. We're just not really going to albumin.
Right. I would totally agree. I think I'm not quite sure the last time I even used an albumin solution outside of sort of a cirrhotic who I'm, trying to, resuscitate, those sorts of patients. And, the other thing I remember even back in my training was, and Joel sort of touched on this, was even just the expense of the albumin. At this point in time, you oftentimes even get a call from your pharmacist saying, what is the indication for this at this point in time? So you're starting to get pushback even at the systems level now, even if you tried to go down that pathway. But yeah, honestly, Stuart, I couldn't remember the last time, or Matt, the last time that I even used 4% albumin for resuscitation.
And I think I heard someone talk about hetastarch, right? So hetastarch it's a synthetic albumin. It's the attempt to get all the advantages of a colloid fluid without all the expense. And these have had, in repeated studies, two primary problems. One, increased bleeding, and the other one, increased acute kidney injury. And we don't have a lot of 1A recommendations in our KDIGO guidelines, but we do have I believe it's a 2B recommendation in for avoiding the use of synthetic colloids in acute kidney injury because of the repeatedly demonstrated signal of acute kidney injury with these drugs.
Yeah, you just got to give renally dosed dopamine with it.
that ought to take care of the situation. Because if you can pair two placebos together, right?
Pascale, let's get us back on track to the crystalloids. Can you tell us what are the crystalloids available? What is a balanced solution versus saline?
Yeah, perfect. So when we're talking about crystalloids, it's basically just electrolytes mixed with water. And so we get to choose what electrolytes are in the water. And when we're talking about saline or 0.9% saline, that's basically sodium and chloride. 9 grams actually of sodium chloride mixed up to a liter of water. And obviously, it only contains sodium and chloride, which is not very similar to the plasma concentration, which can contain many other electrolytes. And so it's obviously not a balanced solution, if that makes sense. When we're talking about balanced solutions, we're then thinking of things like lactated ringers or plasmalite, and these are contain sodium chloride, but also contain potassium. They contain some kind of a buffer, such as lactate or acetate, and they usually contain also some degree of calcium and magnesium in them. And so they more closely resemble basically plasma. I have one thing to note is no solution is actually 100% similar to plasma. They all really don't replace our plasma that well, but they're pretty but yeah, balanced crystalloids are definitely closer to the composition than normal saline.
Can you talk a little bit about the concern people have with lactate? Let's say it's a patient who already has elevated lactate, and now you're giving lactated ringers. That's something that's kind of out there, like you shouldn't do that. Does that make any sense? Does that hold water when you actually...
Yeah, great question. I used to think the same. So basically, if you have a septic patient, a hypotensive patient, someone who's not perfusing their organs, then it's normal that they will shift into anaerobic glycolysis and will just be producing a lot of lactic acid, right? And lactic acid is bad, but what is lactic acid? It's basically just lactate and hydrogen ion. And what's harmful in that molecule is actually the hydrogen ion. That's what's driving the acidosis, and that's what's driving all the complications from acidosis. So the lactate itself is just this accompanying anion, which really doesn't have side effects. And so when you're infusing someone with lactate, sure, you're giving them lactate, but the lactate in lactated ringers is actually sodium lactate, so doesn't contain the hydrogen ion. It doesn't put you at risk for acidosis. I think one thing to really be careful about this, though, is if you have a patient with cirrhosis, then they cannot convert this lactate very quickly. So 60% of lactate metabolism occurs in the liver, and so that will definitely be impaired. So you're giving someone lactated ringers, you're giving them lactate, their lactate will go up. This doesn't mean at all that something bad is happening. But when we are measuring lactic acid, what we are measuring, or what the lab is measuring, is actually lactate. So you can have a sick patient who's now perfusing their kidneys very well because you've adequately resuscitated them with lactated ringers, but their lactate is still high because of all the lactate you gave in LR. And so people should just be cautious about it and realize that it's not under perfusion, it's just lactate accumulating, and that it's not harmful.
I just love that. I had never heard that before. I was reading, the what you wrote for NephMadness, and we had to talk about that. Fascinating. Paul Williams, you knew that, right?
Oh, yeah, of course. Please. I was just waiting for someone to say it. I'm glad I didn't have to jump in. That would have been embarrassing for all parties.
So the other issue with LR that is sometimes brought up as a relative contraindication is hyperkalemia, that a normal saline doesn't have any potassium in it, and LR has about 4 millimoles per liter of potassium. And the intuitive thought is that if the patient has hyperkalemia, don't give them the fluid with more potassium. Right. It seems banal. However, there's been a couple of studies that have looked at this, and the studies actually go the other way. That the thought is that the metabolic acidosis that you produce with the normal saline causes an intracellular shift, and you get potassium moving out of the cells. And the studies have actually shown more hyperkalemia with normal saline than with the balanced solutions. My one hesitation with that data is it's weird that all the studies that have done that have been in kidney transplant patients, which is not kind of your typical story. And it makes me a little worried that it may not be applicable to everybody. So I'm a little skeptical of the data, but that's the data we've got.
Okay. So jury's still out on that one in patients with hyperkalemia, but probably safe is what I'm hearing.
Yeah.
Pascale, do you agree?
Yes.
Okay. All right. So we should consider it if we're in that situation. So Charlie, at your esteemed institution, are you using lactated ringers if you want a so-called balanced solution, or is plasma light available? And do you have any experience using that?
Yeah, so I'm at my esteemed institution is the San Francisco VA, just to reorient people, which is a fantastic place to work, and I love it and whatnot. But as all VAs are wont to do, I'm not sure. So I would have to back up a little bit. Since Smart ED and the SALT trial came out, I have certainly switched from normal saline to LR more frequently. So I have not actually gone down the Hartmann's or the plasma light pathway. So I haven't begged that question of the VA at this point in time. But knowing my institution at this point, my guess is I'm again going to get a phone call saying, why exactly are you going to be using that if we've got LR in our back pocket?
Yeah. Anybody, Stuart, are you using plasma light?
No, I don't use it. It's too expensive comparatively.
When I was at Stuart's institution, I did a IV fluid tasting party. And we tasted lactated ringers, and someone asked, what does what does plasma lights taste like? And another one of the interns said, it tastes like money.
Well, this is a good.
That's true.
You're bringing up a good point, though. Pascale, when you were researching this, did you come across like the prices for saline versus lactated ringers, Hartmann's, or plasma light?
I didn't look into that. I do know, though, that the price of lactated ringers and saline is pretty similar. I'm sorry, I can look it up.
Oh, that's okay. Well, that's what we have Stuart for. Stuart is like,
Right.
Stuart's probably already halfway there. Stuart, maybe we can swing back to that and we'll go to the second part. Paul, I think we have a little bit more to the case here.
Yeah, I think as is our way, we're slowly killing the patient, which feels right. So as we're having this debate, poor Mr. William is sitting in the emergency department and seems like he's ICU bound. So he's actually becoming increasingly tachycardic and tachypnic and hypoxic, and his pressures are starting to get soft. So as the internal medicine debate goes on, we decide the patient's probably going to end up going to the ICU, probably the safest place for him while we're debating his fluid repletion. So Pascale, I guess we've touched on this a little bit, but it might be worth sort of talking about some more recent evidence that's come out. But why can't I just do what I've been taught for my entire life and just use normal saline for this patient? Like, what are the downsides? We sort of talked about comparability, but what are the specific concerns that come along with it?
So, I mean, you can use normal saline. The patients will probably be like the blood pressure will improve, the tachycardia might improve. But there are some concerns with giving normal saline. And I think the big two concerns are the development of metabolic acidosis and the hyperchloremia that can happen with normal saline. So without going into too much details about the metabolic acidosis, but one thing that everyone who's listening should know is it's not a dilutional acidosis as people think it is. It's actually much more complex than that, and it's related to the concentration of cations and anions in the plasma. But basically, giving normal saline does lead to this non-gap metabolic acidosis, which then you can imagine like all the complications of metabolic acidosis that we know of will then eventually happen, including worsening inflammation, worsening coagulopathy, just like lower immune arterial pressures in sick patients. So there's that. I think the other concern is... Anyone want to comment? I think the other concern is the development of hyperchloremia. And that's pretty interesting because looking at renal physiology, the macula densa, which is in the distal tubule of the kidney, is actually a chloride sensor. So you're giving patients normal saline, which contains 154 milliequivalents per liter of chloride, when normal plasma should be like contains around 110 milliequivalents per liter of chloride. And so that's a super large amount of chloride that then gets picked up by the macula densa. The macula densa then releases all these vasoconstrictors to the afferent arterioles, telling them you need to constrict. We're going to decrease the GFR. This patient is losing a lot of fluid with a lot of like chloride and sodium, and so this defense mode just starts, and what it results in is a decrease in GFR and acute kidney injury. So I think there's that part, but there's also more stuff that can happen from the hyperchloremia, including like increased angiotensin, which then leads to more vasoconstriction, increasing in thromboxane release, which then leads to like also more vasoconstriction. And actually, if you look at kidneys, like an MRI of kidneys in real time, where normal saline is being administered, there's actually a decrease in cortical perfusion, all pointing to this chloride actually being harmful to kidney perfusion in general.
One of the important things to recognize when you think about the physiology of the kidney is that the GFR is insanely high compared to the plasma volume. You've got a normal GFR is 100 cc's per minute, and we only have 3 liters of plasma. That means in 30 minutes of filtration, we're going to filter all the plasma. And so the disaster scenario that the kidney has to avoid is it can never have filtration without reabsorption. We know that the kidney reabsorbs 98, 99% of everything that is filtered, and that's essential for survival. And if we don't do that, we're going to literally pee ourselves to death within an hour. And so the critical fact, the part that's hardwired into the kidney, the thing that allows us to have this very, very high GFR compared to plasma volume, is the fact that at the end of the thick ascending limb, after the thick ascending limb of the loop of Henle, there's this macula densa, and it's got this chloride detector. And if it detects increased chloride, that indicates to the kidney that we've had a failure to reabsorb. And that's a situation that is untenable. And the solution to that problem, if any tubule, any one of the tubules, the million nephrons that you have, if any one of them fails to reabsorb adequate chloride, and you get this excess chloride there, it'll shut down that glomeruli by constricting the afferent arteriole, just like Pascale was saying. And so the normal saline with this abnormally high chloride concentration, it accidentally triggers this macula densa chloride detector and will shut down the glomerulus. And we've seen this in a number of different experimental models that have looked at this. Giving this very high chloride dose lowers that GFR in a kind of like totally counterintuitive way. You'd think that giving saline would be something that would increase GFR. Oh, we're giving a big sodium load. But what we see counterintuitively is no, it actually slows it down. And we believe it's because it trips this chloride detector.
Pascale, how does this play out clinically? Because I think a lot of the stuff you're talking about, it's mostly, we see these things happening physiologically, but how does this relate to endpoints? And that's where it's the SMART and the SALT ED trial or the SALTed trial. So how did those kind of guide our thinking on this?
Yeah, so these trials happened after like a long history of really observational studies describing this, like the negative outcomes of higher mortality or higher need for renal replacement therapy in patients who had received saline as compared to those who had received balanced crystalloids. And then last year we had these two big trials, the SALT ED and the SMART trials that were published in the New England Journal, again asking the same questions. The SALT ED trial included patients in the emergency department, whereas the SMART trial including patients in the ICU. And without like the outcomes of both studies were what's called the MAKE 30, and that's a composite outcome.
So great.
I know. So MAKE 30 stands for Major Adverse Kidney Events Within 30 Days, and it's a composite of death, new renal replacement therapy, or persistent renal dysfunction at hospital discharge or at 30 days since admission. And if you look at the outcomes of both studies, so starting with the SALT ED studies, so patients who had arrived to the ED and received saline had 5.6% of having the MAKE 30. The patients who had received balanced crystalloids had a 4.7% of having the MAKE 30. So 4.7% versus 5.6%. It was statistically significant, but all right, I'm not sure if I can make a great conclusion out of this. The SMART trial, similarly, patients who had received saline had a MAKE 30 of 15.4%. Those who had received balanced crystalloids had a MAKE 30 of 14.3%. Again, statistically significant, but a difference of 1%, does that make you change your practice? I'm not sure.
Right. So in both these trials, there was a number needed to treat of 100 patients to get one reduction in this MAKE 30 outcome, which is a outcome that we had not previously been familiar with. But for an innocuous decision about choosing which IV fluid to go with, would you rather have the one that had a 1% lower risk of a adverse kidney outcome or not?
Joel, I like how you put that into perspective. The NNT is such a great way for us to sort of like translate a lot of these trial outcomes into something the way we could think about it on a day-to-day basis. And, at 100 seems like a lot, but if you sort of think about a practicing hospitalist or an ER doc who sees 15 to 20 patients in a day, and granted, they're not all going to sort of require fluid resuscitation, you could see how you could get to those numbers pretty quickly, and whether or not you're actually buying into the idea of MAKE as being a true and reliable sort of outcome. That's not a trivial number to sort of think about.
Stuart, looks like you found the price list.
That's right. I've got your price list for you. So I put it up there. So lactated ringers are a little bit more expensive than normal saline by about $2 or so per unit price. Interestingly, the half normal saline is nearly double the price of normal saline. The cheapest fluid that I had was normal saline, probably because of quantity created, made, whatever, produced. The most expensive were plasma light.
Yeah.
by a factor of like 3 to 4 to
Right.
1.
So that was in the $25 to $36 range.
That's right.
Yeah. Okay. All right. So based on these trials, I think we should move on to some of the other topics here, and maybe we can get some closing. We'll go around the horn here. So Charlie, you've told us a little bit. So what were these trials practice changing for you? And are you sort of like, if your trainees start someone on normal saline, are you feeling strongly enough that you're going to tell them to stop, hang a different bag?
Yeah, I'm not sure if I'm going to use the word practice changing, more like practice transitioning at this point in time. Mainly because I think, most of us physicians, we're kind of wusses when it comes to sort of changing our old school practice. So I've certainly taken it into account, and it certainly has augmented my decisions. And I have called out my trainees at times, sort of saying, why did you choose to use that sort of resuscitation fluid? And should we be considering alternatives at this point? My guess is in a couple of years, I will probably have become a convert at some point.
Pascale?
I think I would still use, I think I will still use normal saline or LR in someone who's otherwise healthy and young. But I think if I have a patient with baseline kidney dysfunction or AKI, I will go with LR after these studies.
That describes like most of the patients that I'm admitting to the hospital.
Yeah.
Okay.
Young, healthy, probably not admitted.
Joel?
I'm definitely on team balance solution. I'm going with LR in just about any time that I get the opportunity to choose the IV fluid. I think it's important to point out the time when you don't choose LR. So if you have a patient with metabolic alkalosis, so especially if after a lot of vomiting or with previous overzealous use of the diuretics, you want to give them that chloride. They thrive on that chloride, and normal saline is the fluid that you should be choosing in that situation. Outside of that, I'm on team LR.
Can you explain that? I don't know that I follow. Why do they thrive on the chloride if let's say their bicarb is like 35 or 40 or something?
Right. So the most common causes of metabolic alkalosis are going to be vomiting and diuretics. And in both of those situations, they have chloride depletion that is driving a lot of their metabolic alkalosis, and replacing that fixes them. And you can do that giving chloride in a lot of different ways. One of my moves always is to be real aggressive with the potassium replacement, because if you give them potassium chloride, you're giving them a lot of chloride, and that'll correct a lot of the metabolic alkalosis. But if you're in a situation where you can give them normal saline, that'll be the fastest way to restore their treat their metabolic alkalosis.
Okay. And as we were talking about before, there are a couple kind of larger trials, I think randomized, double-blinded trials coming out on this topic. So I don't think we've heard the last of this, but I think we've definitely done a pretty thorough job talking about it. Dr. Williams, Dr. Brigham, you guys have any closing comments before we move on?
My trainees have actually been ahead of the curve. I'm at the situation where they're like, so we started LR, and I'm kind of oh, well, that's good then. Like, so it's, usually, I don't have to make the decision anyway. It's already that ship has sailed, but they seem to be making they seem to actually have read the trials and been mindful about their fluid repletion choices even before I did. So good for them, I guess, is what I'm saying.
Stuart?
Yeah. So typically lactated ringers is what I use as a resuscitation fluid, because that's the way that I typically use fluids. I don't use a lot of maintenance fluids. And I don't have a lot of patients that are requiring a ton of chloride. But nevertheless,
I'll say I can't wait to find my first patient that has a benign elevated lactate because they have cirrhosis and someone gave them a bunch of LR.
At least you know the answer then.
Yeah. I'll probably have trouble convincing people that that's the case.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
Thank you. We're committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review. Please review the show on iTunes or contact us at thecurbsiders@gmail.com. A special thanks to our producer for this episode, Justin Berk, and as always, to our social media team, Hannah R. Abrams on Twitter, Beth Garbs Garbatelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I'm Dr. Stuart Kent Brigham.
I often wonder what it's like to be in your head, Stuart. It's always
horrible.
interesting. To watch from the outside is interesting. I've been Dr. Matthew Frank Watto.
Peek behind the curtain. He's recording in total darkness now, but it's completely unclear to the rest of us. I remain Dr. Paul Nelson Williams. Thank you, and good night.
Good night. You can see my eyes.
I know, but it's just like you go to your you like turn the camera off for a while, and then you come back and it's like complete darkness, and like once in a while it's like Sin City, like we just see your glasses glaring, like what's his name from Sin City? I can't remember.
Frank Miller comic.
Yeah,
that's perfect.
What's his name again? I forgot.
It's like the album cover of Bohemian Rhapsody for people on Queen.
This is a 54-year-old obese male with CKD3.
What is going on?
Stuart, we can hear you.
What? How? I muted it.
I don't know. My ears are working.
Probably involves a microphone and some headphones, I would imagine.
So, Pascale, Charlie, this is your first episode with us.
I love it. This is sausage being made right here.
We've recorded over 140 episodes at this point. Stuart's been on the vast majority of them, and it still seems every time like simple things like muted or not muted are still, it still comes up.
There were you ask people who've been married for a really long time, like, what's your secret? How do you keep it fresh? And this is the way. It's just like it's new every single time we do it. Just every episode is like the very first one. It's magic.
Oh, I love it.